Happy Valentine's Day, everyone, and thank you so much for joining in today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds entitled COVID-19 Therapeutics, When and How to Treat COVID-19. As a reminder, this educational series is generously sponsored by a partnership between the California Medical Association and the California Health and Human Services Agency. Here are our speakers' disclosures. Next slide, please. This is our agenda for today and our speakers. Next slide, please. And just a reminder that this series is accredited for CME credit. You'll be sent a survey after the completion of the webinar where you can attest to your attendance. And after you complete that survey, we'll send out your certificates. Next slide, please. In spite of the fact that the COVID-19 public health emergency is set to end in a mere 2 weeks, we've entered another calendar year in which COVID-19 remains a predominant part of many of our lives. A young colleague of mine who just recovered from COVID-19 said, "That was the sickest I've ever been." And COVID-19 still brings severe disease and mortality to vulnerable patients. And though we're armed with a variety of outpatient treatment options for COVID-19, few patients are receiving treatment as recommended by the California Public Health Authorities and the CDC. And patients are actually getting conflicting advice from many physicians about whether they need it. When I recommended that my 75-year-old father get treated, his doctor told him that he didn't qualify for treatment. It's a complex situation, and so we're so grateful today to have Dr. Rita Nguyen and Dr. Kristen Ramers, who are both experts in COVID-19 therapeutics, here to help us understand it today. But first, I'd like to welcome back Dr. Erica Pan, California State Epidemiologist and the Deputy Director of the California Department of Public Health Center for Infectious Diseases, to give us a state of the state of COVID in California 19. Thanks, Erica.
Great. Good afternoon, everyone. Thanks for having me back. I'll just launch right in. I'm going to give you next slide, please. Just a little update again, as usual, on kind of the status of the epi in California now, including other respiratory viruses, a little bit about boosters, because we didn't talk about that last month, and definitely talk a little bit about the ending of the states of emergencies. Next slide. So just to kind of show again, and I typically show some version of this every month, but to kind of show you both the long view of where we've been in this pandemic and then a pullout of kind of where we are now. And just to orient all of you again, the black line is the cases. So you can see, like, historically in that first winter we had, and not that these deaths are to scale, but you can at least see the proportionality of deaths versus cases. So the black line is cases, and then during that first winter we had a really high death rate and high proportion with that blue line, and that has changed over time. During our Omicron surge, again, we saw a huge surge of cases, and then thankfully less deaths and less hospitalizations actually that we saw during that first winter. And then we had other kind of Delta surge is that next big bump, and then a more recent surge over this last winter. And you can see again, the good news is that we've had multiple waves and surges, but you can see in the yellow line that the hospitalizations have thankfully been decreasing in comparison to the bumps in cases over time, and then the ICU as well in the pink. So even with this last surge this past winter, the numbers were much lower than in prior surges as far as hospitalizations, ICU, and deaths. Next slide. What are some of the other trends we continue to watch? As we all know, because there's a lot of testing that happens at home and doesn't get reported, we've been looking at wastewater surveillance across the state. We have seen a lot of plateauing and or some increases in different parts of the state, so we continue to watch that very closely. And then in our next slide, I'll show you again just how to put some perspective on this compared to prior seasons. So this is a busy graphic, but just to orient you again, a different way of looking at the hospital burden of COVID and then a prior flu season in 17-18. So again, huge surge, winter 2021, and then the Omicron surge in the hospitals. And then it's interesting to look that, at a peak in 17-18, which is our last severe flu season, we probably had about 5,000 at a peak then in the hospital during that season. And then during this last winter, the combined respiratory burden of flu plus COVID was a little bit less or about the same. So we have gotten to a point in this last winter where the hospital burden, again, thankfully, was much lower than prior surges and similar to a previous flu season. Next slide. This is also looking at the percent of respiratory deaths this winter compared to, again, prior surges of COVID-19 specifically, and compared to the purple line, which is the 17-18 season. So the percentage of deaths as far as contributing has been much, much lower this past season, and again, similar to a seasonal flu season. Next slide. That being said, I think it's important to note, though, when you look at per capita rates, that the national flu mortality rate, that's the kind of orange line here, is about 10 deaths per capita per year. And then a severe flu season, for comparison, again, that 17-18 is about 15. So those are those orange and red lines there. And you can see how dramatically higher COVID-19, what the mortality rates have been over time in California. So that this last peak, actually, this last winter for COVID specifically, per capita was still much, much higher than a serious flu season. Although thankfully, again, now we are at a rate that is similar to a flu season. Next slide. I didn't show any other comparisons, but you can look on our website too, before I talk about boosters, that there are, of course, ongoing disparities. So of the people that are being hospitalized, it is largely the elderly. Over half have been people over 70. And of course, people who are immunocompromised or have other medical conditions that lead them to be more vulnerable, and of course the impacts of long COVID. But also just wanted to make sure that we continue to show you data to support the use of the bivalent booster, which, as you all know, came out last fall. A recent MMWR just came out that looked at data, and that those who had gotten only the original COVID vaccines were those who got the bivalent booster, were 3 times less likely to die compared to those who had not gotten the bivalent booster who had been vaccinated. And then those who had never received vaccine were actually 14 times more likely to die. So there is, ongoing evolving data on the use of bivalent boosters. We know there is not complete consensus on this, but wanted to show you some of the emerging data on that. Next slide. So this is also something that was recently in the New England Journal, showing, again, you can see that for monovalent vaccine effectiveness, the estimates were closer to 25% against hospitalization or death, whereas you really do increase that with bivalent boosters over 60%. So you can look at that recent publication. Next slide. And then another one that got presented at the ACIP meeting recently, or VRBAC, I can't remember which of those two in the last few weeks, but looking at the IV network again, and looking at COVID-19 hospitalizations amongst healthy adults over 65. And again, you can see that there's vaccine effectiveness comparing the bivalent booster to prior doses, and that there is over 60% effectiveness there as well in that IV network. So wanted to arm you with some good information. Again, there's been some controversies about the effectiveness of the bivalent boosters, and some, again, increasing data there that you can also share with your patients and encourage them to get boosted. Next slide. So I touched on some of the disparities, and you can see, even looking at in California, what are our booster rates amongst those over 65 at highest risk. And at the best in the Bay Area, you can see those bluer regions, we have much higher, but even then it's only about 64% that have gotten boosters in Marin, for example. And you can see the differences across the state by region. And then if you look at our Healthy Places Index quartiles, you can see this is all ages now on the right here, but looking at only a little bit over a third of even our healthiest places index individuals have gotten that booster, and less than 15% in our least healthy places index. And of course, those disparities are really important, again, in those who are more vulnerable or immunocompromised. Next slide. On that note, this is a breakdown, and this is also available to look at on our website. You can look at this by race and by age, and I would just, again, focus on the over 65. Again, we have a lot of work to do here as far as the percent of individuals who've gotten that bivalent booster. It is helpful to note that while we do continue to see disparities, it is encouraging that the gap here is lower than it has been earlier in the pandemic, as far as, for example, our Black individuals over 65 are a little bit less than the state average, but it's not as wide of a gap as we saw earlier in the pandemic. So wanting to encourage you again to really do outreach to your patients, especially those who are most vulnerable to serious illness, because really this data shows you that the bivalent booster can prevent hospitalization and illness. Next slide. And then finally, as Dr. Newell Green mentioned, there are various states of emergencies and public health emergencies that are ending this year. So at the end of this month, the governor's state of emergency is ending. You'll hear a lot more about the impacts of Paxlovid and evolution there. And then you also all likely know that on May 11th is when the federal public health emergency and national emergency declarations end. Some of the timelines on here, we're still kind of pulling together all the information about these different impacts. I think a lot of it really is, a lot of these things have been gradually winding down as far as exemptions or emergency orders that were related to these various declarations. There are a lot of state resources in the field that have been decreasingly utilized that we are demobilizing over time in the next month or two. And then things like the Medi-Cal COVID uninsured program does end at the end of May. And then 6 months after the federal public health emergency is when the commercial out-of-network coverage ends in California. Other Medicaid requirements for no cost sharing for COVID-19 tests and treatment ends in 2024 on September 30th. And then the PrEP Act coverage around some of the immunity and liability things end in 2024. So as we gather more information, and I know there are lots of other great resources, we'll continue to share those in our website and other locations, but continue to gather that. But I think, the bottom line is, that we, again, have been gradually decreasing these things and really learning more and more how to use different tools to adapt to this virus and adapt to it in our midst. And with that, next slide. Wanted to, I think since I last saw you, we've had the beginning of a new Lunar New Year, so a happy cat and rabbit year to those of you that celebrate, and also happy Valentine's to everyone. Hopefully we can do more creative things during low levels of transmission with our masks as well. And just a reminder again that there are smarter steps that we can continue to do depending on your individual setting, your individual vulnerability, and that you can talk to your patients about as far as being up to date on vaccines, wearing masks in appropriate settings, indoor air quality and ventilation. We've made huge strides with that, and continuing to test before high risk or after high risk events. And really, you'll hear so much more about treatment related to that and making sure people get timely treatment, especially if they're at risk, and continuing to stay home when you're sick. And of course, the other one we hadn't put in the Swiss cheese, but that really helped all of us through this winter as well. And just a reminder for all viruses and infections to wash your hands and have good hand hygiene. So with that, I will turn it over. Thanks, everyone.
Thanks so much, Erica. I do like those little mice. So we are very pleased to introduce our next speaker tonight. Today, who's Dr. Rita Nguyen. Dr. Nguyen trained at Stanford, Johns Hopkins, and Brigham and Women's Hospital, and she's an internist who's pursued a career that unites the humanitarian promise of medicine with the pursuit of social justice. She moved from her role at the San Francisco Department of Public Health into her current role as the Assistant Health Officer for the state of California and the Director of Population Health at the California Department of Public Health. She oversees the Centers for Healthy Communities, Family Health, Environmental Health, and Health Statistics and Informatics. And we're so pleased to have you here today, Rita. Thank you.
Thanks so much, Karen. I appreciate it. And so I'm going to give an overview of COVID-19 therapeutics, particularly from a state perspective, and then pass it off to my colleague, Dr. Ramers, to go into some of the more clinical details. And also wanted to give a lay of the land of what's going on in California relative to therapeutics. And so next slide. And so, as you all know, what's out there right now in terms of effective therapeutics are antivirals. The monoclonal antibodies, unfortunately, sequentially, were no longer effective with rise in variants. But the antivirals are still quite effective. Something that I know Christian will go into further detail is that despite being vaccinated, there's actually great benefit to taking the antivirals because there's a reduction in severe disease, which includes hospitalization and death. And I recognize that for a lot of clinicians and the general public, folks are pretty fatigued from COVID, and it's been hard to teach sort of the next layer and the next tool that's been available to us. And it's unfortunate because 3 years ago, this was the moment everybody was desperate for, that there was actually something to do when you tested positive. And for both the public and for clinicians, I think it's been hard to sort of set new norms of how we approach COVID after we've taught really great lessons about testing and isolating. And then now the next step is actually go seek treatment. And so on this slide, I also compared it to the relative risk reduction for other medications that we offer to prevent MI, to control diabetes, and prevent microvascular damage. And so effectiveness rates on the level of 50% is actually quite good for these drugs. Next slide. The other perspective that we have is that, given Erica's slides about the, lower rates of hospitalization and death that happened this winter, it's still worth noting that there's growing and early but growing evidence that treatment of COVID actually is associated with decreased risk of long COVID. And so when we think about the disparities in access to care and the potential for long-term sequelae of COVID, it's really worth noting that we might be preventing sort of the next wave of COVID complications here, which is all these implications for chronic disease and lingering symptoms and fatigue. And so it's something we're keeping an eye on, and we recognize, we're still waiting for more data to come in. And I believe an RCT is going to be completed next year. Next slide, please. This is one of the more interesting and recent studies around long COVID and the reduction in risk for long COVID for treatment, and this is specific to Paxlovid. And they studied a large population of VA patients and saw that there was decreased risk of development of post-acute sequelae or long COVID, even in the vaccinated group, and across a number of different outcomes related to death and hospitalization after the acute illness. Next slide. So again, it's worth noting that unfortunately, as we could have predicted, as we saw many times in the pandemic, that there were disparities in access to care across racial and ethnic lines, across socioeconomic status. So this came out relatively early last year when COVID-19 treatment became more readily available and supply wasn't an issue. And we still saw that even patients presenting to medical care, despite the fact being positive and asking for treatment or being evaluated, that Black and Hispanic patients were being seen and prescribed at much lower rates. Next slide. Unfortunately, in California, it's hard to actually get great data on the demographics of users. From a state perspective, we're limited in what we know about who ultimately accesses and uses treatments. We do know where it's being distributed in terms of zip code and the Healthy Places Index quartile. So Erica mentioned that earlier. And this is sort of a summative metric of socioeconomic status. And so those in HPI 1 and 2 are sort of lower SES. And you can see that disparities still persist despite all our efforts. And so it's really crucial for clinicians who are seeing patients, especially those who are disproportionately impacted and living in zip codes in HPI 1 and 2, to recognize that they are being treated at lower rates. They seek it at lower rates, but as we saw in the CDC study, even if they are seeking, communities of color are being prescribed at lower rates. The dotted line gives you a summation of the share of all Paxlovid that's being administered that is in HPI 1 or 2. And so ideally this would be closer to 50%, but it's not, it's still not. And our best data is on Paxlovid, and that's why I'm highlighting that here. Next slide, please. And we've also seen over time that the share of deaths in those over 65 has unfortunately worsened. We would think that over time we would do better by this crowd, but that's not been the case. And so it's even more important to recognize what tools are still available, which is treatment, especially for those who are older. Next slide. And amongst the most vulnerable in our communities is those living in long-term care facilities and SNFs. And you can see that treatment rates are surprisingly low. So this is among SNF residents, which by virtue of living in a SNF, you're qualified as high risk. So all of them should be qualified when they test positive for COVID. We're up to about 40% of SNF residents who are COVID positive being treated. Thankfully, there's a trend upwards, but still a ways to go. Next slide. So we rank 18th in the state for our rate of treatment for SNF cases. This is an improvement, but you can see our colleagues in New York and Washington. Oh, actually, Washington is above us, and New York is just a couple ranks behind. Next slide, please. And so I wanted to go through common reasons that clinicians typically relay for not prescribing. And to Kim's point, we still hear almost weekly stories of folks, even within CDPH, who can't access COVID therapeutics for their loved ones for any number of reasons. So I'm going to go through these and be very sort of pointed on what we've been hearing and hope to provide the evidence to clear up any misperception. So one thing we hear is that patients have mild symptoms. Next slide. But it's worth noting that that's actually one of the indications for treatment, is that you have to have mild to moderate disease. And so this isn't a disease where you sort of wait and see if things get worse. If you think about it, everybody who eventually gets severe disease started off mild. And the whole point with COVID therapeutics is to treat early. You're only eligible for treatment within 5 to 7 days of symptom onset. So that does make it really hard for patients to present quickly enough to care and then be connected to provider when they seek treatment. Next slide. Another one that we've heard is that patient does not have a high-risk condition. So this is a common misperception. And so I encourage you all to re-examine this. Next slide. So actually, if a patient is 50 or over, CDPH and others have been quite clear that this is already a high-risk category, regardless of whether or not you have any other comorbidities. Next slide. And this is summarized by the CDC table in terms of risk for hospitalization and death. And you can see between 40 and 49 to the next tier, there's a jump in hospitalization and death. And so although early on, I think folks have sort of memorized the 65 number, when you look at the data, age 50 and plus is actually quite high risk. Next slide. Some other common reasons why people would actually qualify is being physically inactive. So I think most clinicians don't recognize that that's actually on the CDC guidelines. When the NIH and the FDA point folks to higher risk conditions, physical inactivity is one of them. I've listed a couple other common ones. And at the end of the day, what this translates to is the vast majority of adults qualify for treatments. Back in 2020, when the CDC first came up with their list of high-risk conditions, they had already estimated that that was 60% of adults. And since then, they've added a lot more categories, including physical inactivity and racial and ethnic minorities. And so in practice, most adults qualify for treatment. And then, of course, those who are 12 and older, if you have one of these conditions, you qualify as well. I'm highlighting here the racial and ethnic minority piece, and that's on the CDC page as well, on the clinician site. Next slide. This table summarizes what the CDC has put together in terms of higher risk categories, and I've tried to circle here common ones that I think folks are unaware actually qualify folks for therapeutics, and it includes smoking, depression, disabilities, and obesity. Next slide. So another common reason we hear is that treatments are in short supply, so I must prioritize for those who are very high risk. When in fact, there's actually been ample supply of COVID treatments since the spring of 2022. So unfortunately, I think we learned too well this scarcity model and felt like we had to memorize prioritization schedules, but that's not the case. There's been enough treatments out there. If local health departments and clinics ask for them, then the state can supply, and they've been purchased by the federal government. Next slide. Another one is that clinicians are sort of placing this bar on patients to prove that they actually had a positive SARS-CoV-2 test, when in fact, next slide. So the FDA, EU, and EUA never actually specified that there was a requirement of test verification. It did advise that folks should have a positive test. And even then, actually just a few weeks ago, the FDA revised its EUA for the oral antivirals and said that there's no longer required that people even get tested prior to prescribing antiviral medications. Part of that was in answer to sort of the clinical situation in which you have a close contact, like a household contact, which then develops symptoms consistent with COVID, and then you can sort of empirically treat despite the fact that the test may come back negative. And so for a number of reasons, folks don't need to prove that they were positive, that by self-report should be adequate, or no test at all if there's clinical judgment warrants. Next slide. Another one is that I need labs to prescribe for my patient. I don't know what their renal or liver function is like. Next slide. So again, HHS and the EUA actually make it pretty clear that this only for pharmacists is it actually required that you have renal and hepatic labs. And there's this piece of clarification from ASPR and HHS here that pointedly ask, are labs required? And it does specify that as long as you're not a pharmacist, but you're a licensed physician and advanced practice providers, you're not required to test, and you can use clinical judgment to determine if labs are necessary. Next slide. And then I understand, folks, it might make folks nervous whether or not you should be prescribing the renal dose of Paxlovid. And so what if you don't get the labs and you miss that the renal impairment, that there actually is mild to moderate renal impairment? And so it's worth noting that the renal dose of Paxlovid really just changes the dose of the nirmatrelvir and not the ritonavir. And so if you look at what is the clinical impact of having elevated levels of nirmatrelvir because the kidneys aren't clearing it, then we actually looked into this, and it's actually just elevated levels of the drug, which can cause side effects such as dysgeusia, diarrhea, and myalgia. And then it's worth weighing the clinical impacts of having to deal with potential side effects versus the risk of hospitalization and death from foregoing treatment for clinicians, for our patients. And then in terms of renal impairment with GFR less than 30, and so it's not that there was actually harm that was demonstrated, it was more that an appropriate dose had not yet been determined, it hasn't been studied. Next slide. And another common concern we've heard about is that the patient's older, and I'm worried that it's not safe for older adults. Next slide. There's some irony there in that those who are older than 70 or 80 are amongst the most likely to benefit and have high impacts from taking treatments. And so you could see here the risk of hospitalization and death for those over the age of 75. Next slide. I'll go through these quickly, but the resources will be there. There's a number of studies who pointedly looked at older adults to study the effectiveness. And here, the average age of this study was 76. Next slide. The next one, average age of 77 for Paxlovid and 80 for molnupiravir amongst those in the study. Next one. This was also a study about Paxlovid, and again, the median age of those studied here were 82. And so there has been a fair amount of studies done in the older group to determine whether or not there was sort of unexpected complications of treating in older adults, and that hasn't really bore out. Next slide. And the final two, I'm going to hand it off to Christian later to go into further detail around the evidence behind continued benefit, despite the fact that patients are vaccinated or have previously been infected. Next slide. And so all of this to sum up are the reasons why CDPH put out a health advisory at the beginning of December, which summarized many of these main points about the potential benefit for long COVID, the reasons not to prescribe. And the perspective here is that all symptomatic patients with a positive COVID test of any type should be evaluated for treatment. That's not to say everyone should get treatment, but everyone should be evaluated because unfortunately, even the public excludes themselves by saying that I'm not high risk. Most people don't think they're high risk when in fact, most adults are actually high risk and would qualify. Next slide. And again, these are some of the highlights from that health advisory, which advises that providers should have a low threshold to prescribe, given the broad range of folks who are eligible, and that the decision to not prescribe should really be reserved for situations in which the risk of prescribing clearly outweighs the benefits of treatment and the potential benefits around hospitalization, death, and long COVID. And again, it reiterates some of the common reasons that folks state for why they withhold treatment, but there's actually references and data to suggest why that shouldn't be the case. And you can check out the KHAN here. Next slide. Just a couple more challenges, navigating drug-drug interactions. So I'll really turn it over to Christian to handle that, as well as understandably, it's difficult to stay up to date with the evolving field. So CDPH is truly happy to support clinicians as we are absolute partners in this. Next slide. So just last month, we stood up a clinical consult line, and this is for any California healthcare provider. It's free, it's confidential, you don't have to give PHI, and you could speak to clinicians or pharmacists to help with navigating drug-drug interactions or talk about anything else that you might find challenging about therapeutics. And we also have the ECHO webinar series, which I'll let Christian talk more about. And this is all to support clinicians to stay up to date. Next slide. We also hear from clinicians and from health systems that patients present too late to care. Next slide. It's worth noting that when we do a review of health systems and we gave them a score of level 1, 2, or 3 for the quality of information, unfortunately, when we reviewed this in August, we saw that the vast majority of health systems actually had no information or misinformation about COVID treatments, or they didn't have easy pathways for patients to access. So if patients are presenting late to care, part of it is that they have difficulty accessing a provider quickly enough. And so you can see over time in December, folks who had level 3 information, which is the best, that's the light blue, improved, which is great, but it's still a minority of health systems in their sites that make it possible for patients to reach a clinician quickly. Next slide. We saw a similar pattern among health plans. So if you're not even sure who your doctor is and you're trying to call your insurance card or go to their website, we were also seeing that either there was no information on treatment, or the sites were still telling people just sit home and isolate, or they would point to the CDC or the HHS website locator for how to seek care rather than actually pointing into their own provider network. Next slide. In terms of call to action, so for all you clinicians out there, especially those who work closely with the workflows and your practice managers and medical directors, there's absolutely an opportunity here to update all your patient access points to make sure that those who are presenting symptomatic or with a known positive COVID test actually can reach a provider within 24 to 48 hours. We have a number of resources available to you, and to really try to normalize treatment for COVID-19, that when folks test positive and they seek treatment, that you make it available, and that this is available to them. Next slide. And so we have a number of different resources for providers. You can email this web address to get the resources. Next slide. It takes us a while to post things on the website. We have checklists for skilled nursing facilities and RCFEs. Next slide. And a host of handouts, graphics, social media, and posters to put in your clinics. Next slide. And again, in the vein of trying to normalize, some of you may have seen the public media campaign that we put out in the last several months to help the public recognize that we are at a different stage in the pandemic and new resources are available to them. And with that, I'll end it on our jingle. We just have 15 seconds of our Spanish version as well.
Chistes de garganta, rasposita, tienes tosecita y sospechas del COVID. Tienes 5 días para poder ganarle al COVID. Hazte la prueba, toma las pastillas, gánale al COVID. Así. Estos tratamientos son seguros y sin.
And with that, I'll pass it off to Christian. Thank you.
Thanks so much. That was really fun. I was dancing. I won't out anybody else to see if they were dancing to that too. Thank you, Rita. And now I'd like to introduce Dr. Christian Reimers. Dr. Reimers trained at the University of California, San Diego, at Duke University Medical Center at the University of Washington. He is double boarded, if I get it right, in internal medicine pediatrics, has an MPH, completed a fellowship in adult infectious diseases, and is board certified in addiction medicine. He currently serves as the medical director of the Laura Rodriguez Research Institute and the director of GME, Graduate Medical Education, at Family Health Centers of San Diego. He leads several clinical and educational research projects that you should read about online, and he also maintains a busy bilingual clinical practice, providing specialty and primary care to underserved and homeless individuals of all ages. So thank you so much for making the time in that busy schedule to present to us today, Christian.
Great, thank you so much, Kimberly. And boy, hard to follow that jingle without my guitar with me here, but I think the theme and the sort of idea is been settled by Rita and and Erica that we're sort of moving into a new phase. The emergency declarations are ending soon. And this really should be a routine disease that we know how to take care of, and we do have really great tools to do so. So that's going to be my theme as well. And I think Rita's done a really nice job of kind of setting the stage with the standard recs and the efficacy of these drugs. I'm going to go through a little bit of the issues on the margin. So I just have a couple slides on variants to address that issue. I'll talk a little bit about selecting appropriate therapy, and then I'll go mostly into nirmatrelvir, ritonavir, or Paxlovid, talking about what it really looks like in the real world in vaccinated patients, since most people have been exposed or vaccinated. A couple other questions that constantly come up are what about pregnancy, use of Paxlovid in pregnancy, COVID rebound phenomenon, and then drug interactions, one of the major reasons that people are reluctant to prescribe this medication. I have remdesivir and molnupiravir listed on there as well, because that is sort of the second and third option on the NIH guidelines. I don't really have specific slides on that, but hopefully we can get to that in the Q&A. Next slide. So a couple slides on variants. I like to just bedazzle everybody with the complexity of variant evolution, which it really is quite complicated, and really more complicated than we thought it was going to be. But all of this, these letters and alphabet soups are really just versions of the SARS-CoV-2 virus, really altering the spike protein slightly with different mutations that you can see on those multicolored boxes on the bottom, to the point where they can sort of evade the immune system a little bit better and continue to exist. That's really what they're trying to do. The main variant that we have left, the two main ones are BQ1.1 on the bottom there, and then XBB1.5. The X is because it's a cross between two other variants there. And if we go to the next slide, the CDC has been tracking this, and you can see that XBB is predicted to be kind of the dominant strain, with BQ1.1 kind of fading a little bit in the distance. And the next slide, please. And it's just sort of swept usually from the Northeast down to the West Coast, and you can see that the XBB, which is that dark blue, is almost completely dominant in the Northeast and in New York. And we're still, we still have about 55% or so in the West Coast, and that's probably rising. In my own clinic, we're seeing a little bit more of a bump right now, not a full-on surge, but it's probably that XBB variant making its way across the country. XBB is a little bit more unique than really what we've seen, and this chart on the bottom shows you the sort of reproductive time of all these different variants that we've had through the last 3 years. And the one outlier, that red dot way up high there, is actually XBB. So it is felt to be kind of the most contagious version that we've seen so far, probably binds the ACE2 receptor more strongly with higher affinity than many of the other variants because of all those accumulated mutations. Next slide. So we had a really unfortunate thing happen, which is our really good therapies, the monoclonal antibody therapies, which we used extensively during the worst times of the pandemic, really started to lose activity against these new variants. What you see on the top here in this New England Journal of Medicine publication is that as the concentration of the monoclonal antibody increases on the x-axis, the activity really lost its steepness there when we got into these new variants, the BQ1.1 in yellow and the XBB in red, to the point where bebtelovimab, which was really our last active monoclonal antibody standing, it was completely flat, meaning it just didn't have any activity at all. And then silgavimab, which is part of Evusheld that we use for prevention, really flat completely. And sotrovimab, which was supposed to be the one that sort of stayed active against everything, really not really good at all. But the good news here, if we go to the next slide, is that our antivirals still retain all of their activity. So we have the three that I mentioned earlier, the nirmatrelvir, which is part of Paxlovid, remdesivir, which is an IV formulation, and molnupiravir. These curves really look like they're not changed at all, even with these brand new variants, the BQ1.1 and XBB. So we should have really full confidence that these antivirals still continue to work. And it makes sense because these medicines don't target the spike protein at all, really. They work inside the cell. Next slide. And let's advance one more as well. So to address a couple of the things that Rita brought up in terms of reasons why patients are not treated, I really wanted to go back to basics and what we understand about COVID-19, the disease. And that is that there is a viral phase in the very beginning, and there's sort of a honeymoon period in the middle, and then really a host inflammatory response phase at the end. And that typically doesn't happen until 7 to 10 days after initial symptoms. So the approach that many clinicians have taken in my own system and elsewhere is that they just sort of wait and see, and they want to see how somebody does. And that's really the wrong approach to this disease. If you just wait and see, you'll get 5 to 7 days into the illness before people start getting sicker. And by that point, you're really out of the window when an antiviral would be efficacious. So treating as soon as possible, right in the very beginning, is really the way to do it. And what we have to do is make an assessment of risk factors and whether somebody deserves to be treated. And as Rita mentioned, that's pretty much everybody. It is very rare that you're going to find somebody fully vaccinated, young, with no risk factors that really doesn't need treatment. We still see those people, but the vast majority of people are going to have at least one risk factor for severe disease, which means they should be treated very, very early. And if we could go to the next slide. I just have this sort of green to red sort of stoplight here just to show that there is an incredible diversity of presenting symptoms. As an infectious disease doctor, I'll tell you, this is not a respiratory infection. This is a systemic infection that really attacks vasculature and the endothelium really throughout the body, and then has some bizarre relationship with our immune system where it's like kryptonite and causes incredibly high inflammatory responses that result in things like long COVID and multi-system inflammatory syndrome in adults and children, and a whole lot of thromboembolic disease as well. Next slide. So I like to put up this scheme here, not to confuse people or make things too complicated, but that we have been in places where we've had to prioritize. But we're really not there anymore. This takes into account a person's age, their medical conditions, their vaccination status, and their immunologic status there. And we generally think of left to right going from low risk to high risk, but really anybody except for someone that is really young without any medical conditions, who's fully vaccinated and not immunosuppressed, anybody else really merits treatment. And again, we don't need to be prioritizing for only those on the bottom right of the scheme here. And as Rita mentioned, really 50 is the age where the mortality really starts to go up quite steeply. So really anybody with any risk factors should receive treatment. Next slide, please. So let's get to the therapeutics, the 3 that we have here, and the next slide. And then one more here. I'd like to put this up just to show our closet in our clinic, showing that there is really not a scarcity at all of Paxlovid anymore. It's just being underutilized. Next slide. So you may be aware of the initial approval trial for Paxlovid that showed that it was about an 88% reduction in the primary outcome of hospitalization or death. But that trial was conducted in an unvaccinated population relatively early on in the pandemic. And what's now much more relevant is a study like this. So I'm going to go into some depth into this because it really gives us answers about what Paxlovid can do for us now in 2023, where most people have either had COVID before or been vaccinated. This is a very large population-based cohort with inverse probability weighted models, which allows a comparison as if it was a randomized trial here, conducted in a large healthcare system of over 1.5 million patients during the Omicron wave in Massachusetts and New Hampshire by colleagues at Massachusetts General Hospital. So they had 44,000 patients who were not hospitalized, mild to moderate disease, over 90% of them having received greater than or equal to 3 vaccines, and people had to be above age 50 with no contraindications to make it into the study. The endpoint was similar to what we saw in randomized trials of Paxlovid, which is a composite of hospitalization and death. And the results were that only about 30% of people were prescribed nirmatrelvir ritonavir, which right there just shows you that this is kind of being underprescribed. And the composite outcome occurred in only 0.5% of those receiving the Paxlovid or nirmatrelvir ritonavir, and close to 1% of those that did not receive it. Now, what does that tell you? Right up front, it tells you that the rates of hospitalization death of COVID are lower than they have been over the last couple of years. In the initial registrational trials, this was more like 5 to 6% risk of hospitalization or death. So that's good. That's probably because of immunologic experience. But we still have about a 44% or around 70% reduction in death, 44% in the composite outcome. And so the conclusions here are that the overall risk of hospitalization death has been decreased by our immunologic experience, but nirmatrelvir and ritonavir still reduces this even further at close to a 50% risk reduction. And Rita did a really good job of comparing that to other things that we consider to be standard of care, like statins and like glycemic control in diabetes, which I think we would all lose our licenses if we just decided to stop caring about glycemic control in diabetes. But those relative risk reductions are in the 20%, whereas this actually is more like 44% even now. And I think really what's happening is people are just fatigued of hearing about COVID, and they've just lost sight of the fact that we still have an incredibly effective therapeutic that we should be using. Next slide. So just a visual to show you this large light green COVID waves, and then the dark green is those that actually got the nirmatrelvir ritonavir. Keep in mind, everybody in this study was above age 50, so theoretically, almost all of them should have been receiving it. Next slide. And I just show the Kaplan-Meier curves very quickly. The composite endpoint, very clear separation of these curves. Hospitalizations, also very clear separation of the curves. And then deaths within 28 days, very clear separation. And all of those relative risk reductions were statistically significant. And next slide. In subgroup analyses, we do see kind of greater benefit with people with more risk factors. So there's a tighter error bar around those that are 65 and older, but there's still a benefit for those that are 50 to 65. A tighter error bar, much farther to the left in those that are not fully vaccinated than those who are vaccinated. And then also a bigger effect in those that have not been vaccinated recently. A bigger effect in those that have had higher monoclonal antibody screening scores, which is a measure of comorbidities, and then a bigger effect in those that are obese. So obviously people that have the higher risk factors are going to benefit even more, but the bottom line is the benefit is essentially there for everybody with even a single risk factor. Next slide. Let's talk about the reasons why people are not using Paxlovid, and I'll start with ritonavir, and we can go next slide through the graphics here. Ritonavir, if you're not familiar with it, is a HIV protease inhibitor that was also observed to be an inhibitor of the cytochrome P450 enzymes, resulting in slower metabolism of drugs that are metabolized by this system. So an example here is midazolam, and if we go forward to the next slide, I'll show you, I think, diltiazem, where basically the ritonavir, when it's present, it really changes the area under the curve of that drug, and we've used this advantageously for HIV medicines like protease inhibitors, and we use it advantageously in Paxlovid as well. And we just need to know basically how to use it. Next slide. And when you think about a COVID patient in front of you, you should be able to sort of classify them as having no drug interactions at all. That would be the people in the green. This is from an ACP Annals of Internal Medicine. You have sort of light yellow and then orange, which are drug interactions that really just need to be thought about or managed. And then there's a really smaller number of people that are going to be in the red. And there's a study looking at French hospitals of people admitted with COVID that estimates it's about 10% or so that are going to fall into that red zone, meaning 90% of people can easily receive a drug like this with just a little bit of thought. And the questions that you really have to ask yourself is that can an interacting medication be withheld, such as a statin that people are taking for really long-term benefit? Can it be held for 5 days or maybe 8 days? Can the dose be adjusted? So somebody, for example, who's taking amlodipine for hypertension, maybe they just cut the dose in half while they're on Paxlovid. And then can we just clinically monitor, for example, somebody who's on Coumadin, which has a slight interaction, can we just monitor an INR during treatment? And the request here, the call for action is that if you do confront a drug-drug interaction, utilize your resources, utilize your pharmacist nearby, utilize a drug interaction website, which I'll show you on the next slide. And then, take a second to think about it and make sure your patient receives adequate care and can actually get the antiviral that they need. Next slide. So my favorite resource is the University of Liverpool in the UK. It's covid19-druginteractions.org. They've been creating drug interaction websites like this for HIV, hepatitis C, and now there's one for COVID. And essentially, it's very user-friendly. I use this all the time when I'm talking to people and they're going through their med list. It's very easy to put these things in very quickly. Let's go through the animations on this slide, and I'll just show you what it looks like. You enter things. I entered apixaban in here for this particular patient, flecainide, and other things. It'll generate a quick table showing you interaction with different medications. You can see that molnupiravir interacts with pretty much nothing, and remdesivir has a smaller interaction profile. But in the middle there, you have Paxlovid or nirmatrelvir or ritonavir. And there's really only one in this case, which is an absolute contraindication. That's the flecainide, and the other ones really can be managed by either holding or reducing doses. Next slide, you'll just see the flecainide. There are some where you just really shouldn't mess with them, and antiarrhythmics is one of those. But again, this is going to be a small minority of patients, right around 10%. Next slide. Renal function, I think Rita mentioned this as well. It's really not complicated and it's not that big a deal. People with normal renal function, the dose is standard. People with reduced renal function, we just drop the nirmatrelvir component in half. And then if we have severe renal impairment, it's not recommended, mainly just because the studies have not been done yet at this point. And next slide. Just to make things not confusing, in the very beginning, we had to pop out those pills ourselves with those little gray circles there, but go to the next slide. There's now a manufactured version, which is a completely different color. Actually, that's the renal package that you should have available to you if you find somebody in that 30 to 60 GFR range. Next slide. Another issue is pregnancy. We are generally reluctant to use medications in pregnancy because of lack of data, but the American College of OBGYN actually issued this statement way back in January of 2022, essentially saying that there's it's a risk-benefit discussion, but there's really not any evidence of fetal harm with nirmatrelvir. And ritonavir has been used for decades in women living with HIV. So essentially, pregnancy, given that in and of itself is a high risk factor for severe outcomes, including poor pregnancy outcomes, that all women who are pregnant should be offered nirmatrelvir or ritonavir. The WHO was a little more conservative up until recently. They said, well, maybe there's not enough data, we should not recommend this, but they actually just overturned that and said that it should be offered to pregnant women. Next slide. And then finally, we can go two more in the animations here. The phenomenon of Paxlovid rebound, or what it really should be called is COVID rebound, because as I went through, the natural history of COVID is that 7 to 10 days later, you can have this surge in symptoms. This is a study really trying to identify if this is a real thing. And I'll just zone in on the viral testing rebound row here in the study here, where they found that people that took Paxlovid had about a 14% rate of viral rebound, and those without Paxlovid had a 9% rebound rate, and so it was not really statistically significant here. So this is really part of the natural history. We certainly need to study it and understand it more, but it absolutely should not be a reason not to treat somebody. The rebounds that I've seen have universally been mild, and I'm not aware of anybody that's actually had a severe outcome from a rebound. It is a little bit of a bummer because you probably are contagious again. And if we go to the next slide, CDC issued a health alert saying what we should do in this situation, saying, first of all, that a brief return of symptoms may be part of the natural history. Limited information on case report is that these are universally mild, and there's no evidence that additional treatment should need to be undertaken. However, an additional 5 days of isolation is actually advised. Next slide. Okay, I think I'm done here. I just want to finish by mentioning that the CDPH has been generous enough to support an ECHO program, which is really just a way to support clinicians out there in California that are treating COVID so that we can all incorporate this as part of our routine practice. There's a registration link that you can see there. We're doing webinars every month and then sort of smaller groups every month as well, and breaking it down into the Northern California region and the Southern California region. And everybody's welcome. The webinars are a little bit more formal with sort of didactic presentations, and then the office hours are much more to answer people's questions and go over cases. And the next slide, I think, just has our next couple of sessions. Really a brief program that's going to end in May because we anticipate there'll be a lot less COVID by then. The first 2 sessions that happened that were outpatient therapeutics and testing are available to see the recordings, and then those are the ones coming up in March, April, and May. And the next slide, just to plug one more time, there's also a warm line that you can see there. Our colleagues at UCSF, the National Clinical Consultation Center, are basically on call to answer your COVID questions, really to give nobody an excuse anymore for not using these therapeutics that we have. And I'll finish there. Thank you very much.
Wonderful. Thanks so much, Dr. Ramers. And I feel a lot more educated about this than I did before. As always, we have tons of questions from our audience and won't have time, unfortunately, for all of them, but let's do sort of a speed round to try to get through some of these. I just wanted to sort of drill down on a couple of very specific questions people asked about therapeutics, just again to tie as clinical examples all of this information you've shared. So Dr. Ramers, what would you do with a 91-year-old patient with a history of mitral valve replacement and a pacemaker who's currently medically stable? The participant said that someone had recommended that they not take Paxlovid. Should he be prescribed Paxlovid?
Well, without knowing the medications he's on, absolutely the risk factors just by age and by comorbidities. And this is the type of patient we're seeing now that's really having trouble with COVID and still dying of COVID, to be frank. The fact that he has a pacemaker might mean that he's on antiarrhythmic. So I would need to do a drug interaction check. And then just as I treat everybody else, if there's something that's bright red and is contraindicated, I would stay away from Paxlovid. But if there's something that's orange, I would manage it and certainly get that patient treated.
Great, thank you. And what about hospitalized patients? Should anyone who's hospitalized who has COVID be given Paxlovid, or depends on how sick they are?
Yeah, I can take that too. So, the drug is approved for outpatient use. So if they're sick enough to be in the hospital because of hypoxia, they really shouldn't be getting Paxlovid. There's an interesting kind of gray area where if they're in the hospital not because of COVID, but because of something else, then the NIH guidelines refer you to the outpatient treatment guidelines where they could receive Paxlovid or IV remdesivir, theoretically, with a 3-day course there. So that's a little bit of a judgment call as to whether the hospitalization is caused by COVID or not. If it is caused by COVID, then we need to think more about IV remdesivir and then steroids.
Great. Thank you. And then speaking of remdesivir, for those patients for whom Paxlovid is contraindicated, what is the next therapeutic option, and is remdesivir on the menu?
Yes, it is. The NIH menu is pretty clear. It's recommended Paxlovid #1. Remdesivir is still at that recommended stage, but just logistically a lot harder to deal with because it's an IV course for 3 days. We've managed to finally solve that problem, and we're doing it in our clinic for those that can't get it. But I understand it's not widely available. So if you can't do that, then the third line is molnupiravir. And molnupiravir has a little bit more to think about. It's not really a good choice for women of childbearing age or pregnant women or children. So the indication is 18 years and above. I think it's better than nothing. The efficacy is certainly less than Paxlovid or remdesivir, but in a high-risk patient who can't take either of those, I would certainly use molnupiravir, and it's a 5-day course, just like Paxlovid is.
The benefit of molnupiravir is that there's no known drug interactions in the same way that is the case for Paxlovid because it has the ritonavir component.
Great. Thank you both. A lot of people are asking about travel. And so the question is, can you take a Paxlovid prophylactically and or have it prophylactically prescribed so that if you get ill while you're traveling, you can have a treatment option? Thoughts on that?
Delicate question. I will say what I have done, which may be a little bit off-label. So first of all, Paxlovid is not fully FDA approved yet. So, once a drug is fully FDA approved, clinicians are given a lot more leeway to use things off-label based on their own judgment. Under the specific EUA, though, I think that is probably not authorized at this point. Definitely not authorized to use prophylactically. That's not the indication of the drug. This is a little bit of a tough judgment call. I would say that in extremely high-risk patients traveling to places where I know Paxlovid is not available, I hope the medical board's not listening, but I have prescribed in that situation, not to be used prophylactically, but as sort of an anticipatory use of the drug should they have symptoms or test positive.
Great, thank you. We promise not to tell. So speaking of emergency use, can we talk for just a minute about what happens to Paxlovid coverage and cost after the public health emergency? And Erica, in some of your slides, it sort of alluded to how that is evolving, but do you have any sort of understanding of what that's going to look like? And
I might actually ask Rita to answer that one.
Yeah, so the issues around EUA and coverage for the drug isn't, well, not coverage, but the issues on EUA is not related to the end of the state of emergency. That's separate. The piece around the cost of drugs has more to do with the timing of commercialization, which is also independent of the end of the state of emergency. The one piece around therapeutics that is time bound with the end of the state of emergency is the health plan coverage for it. And so in California, a new law last September obligated most health plans to cover for the care of COVID-19 therapeutics. So that includes the visit as well as the drug. It's for Medi-Cal and commercial plans. It didn't include Medicare, unfortunately. And so plans are actually obligated to pay for out-of-network coverage for COVID-19 care up until November. So it's 6 months after the end of the federal state of emergency.
Okay. Very interesting. Well, we'll report out on that as that evolves, because several participants are still talking about the fact, as we said, that Paxlovid seems not to be readily available, even though, as we've seen, there's lots of drugs. So is there inconsistent availability within individual clinics, or what is it that's keeping it from being readily available still?
Yeah, it's actually been readily available since March of last year, where supply in the state warehouses was just sitting, that folks weren't asking, because I think a lot of clinicians perceived that there was a shortage and therefore weren't asking. And so the way distribution works is the federal government has paid for all this. They're free medications. They get sent to the state distributes to the local health departments, and then local health departments distribute to clinicians and systems. And so it's a matter of registering yourselves with the county and then being able to access the supply. But because it's not commercialized, it is being funneled through that way. When it is commercialized, then folks won't be accessing through the state.
That's really helpful. Yeah. Okay, wonderful. Well, unfortunately, it is 1 o'clock, and that's all the time we have today for questions. I really want to thank you all, Erica, Rita, and Christian, for presenting this content, and everybody for listening in today. As we finish up today, we want to highlight the results of CMA's Test to Treat program, which you can see here. And then just to remember that we will send you a survey around 5 p.m. today where you can attest to attendance. Our next webinar is March 14th, and we hope to see you then. Look for us on covidroundca.com. Thanks so much.